Joining us now is Dr. Amesh Adalja, a senior scholar at the Johns Hopkins University Center for Health Security. Dr. Adalja, thank you so much for talking to us tonight. I really appreciate you being here.
Sure. Thanks for having me.
First, let me just ask you if anything that I've said thus far strikes you as wrong or backwards, or if I'm already asking dumb questions.
No, I definitely think the points you made about not notifying which nursing homes have outbreaks, which workplaces have outbreaks, that's the exact opposite of what you want to do in an infectious disease emergency. You want full transparency. You want the public to be completely informed so that they can take the best action. So that's definitely something that we need to emphasize. The points you made about fever screening being not this panacea, that again is something I completely agree with.
In terms of the fever screening, I feel like when we saw initial reports that companies like Walmart or other large companies were going to start fever screening for their employees, it seemed like the first initial sense that a big organization with a lot of equity for this crisis was at least starting to take seriously the possibility that their employees were going to be bringing it into the workplace. Now that we've learned so much more about asymptomatic transmission and just the number of people who can be, the proportion of people who can be positive while asymptomatic, it's made me rethink whether or not those were good moves initially. It's made me worry that maybe fever screening is a kind of security feeder that makes people feel more confident than they should, as if it were a real screening when it's really not.
That is definitely true about fever screening because there are many people that don't have fevers. So people can take Tylenol or ibuprofen and that can suppress the fever. There are airports around the country, even in a non-pandemic time, not in the country, in other countries, that have done fever screening and haven't gotten much value from it. So that's not something I technically recommend as a sole standalone type of thing. You really have to, if you're going to be screening people, you really have to think about all the other symptoms. Do you have a fever? Not just do you have a fever, sore throat, cough, muscle aches and pains, shortness of breath, all of those types of things are what you have to use when you're screening, and that's what many hospitals do. The question about asymptomatic transmission is one that's still very controversial. We still don't quite understand what the context is when asymptomatic transmission occurs. We know it happens in households. We know there have been reports about it, but we still don't quite understand how common it is. We know it does occur, and it's something that in a scientific question that we really need to answer about asymptomatic transmission when we start thinking about how do you screen people going back to work in meatpacking plants, for example, in hospitals, other places like that.
Does it make sense from a medical perspective, scientific perspective, for people who work in high-risk environments like a meatpacking plant to be tested and then to be told to go to work on the line, to go into the factory and start working while they are awaiting their test results?
No, we know that meatpacking plants are a place where it's a congregate setting, it's indoor. We've seen explosive outbreaks in meatpacking plants, often in rural areas, which can easily inundate a hospital or the contact tracers at a health department. So we want to make sure that those places are safe. So if you're giving a test, you probably should have that person stay away from the plant until you get the result back and then let them work. That's the only reason, that's the only way that the testing actually makes sense because of what might happen in a place where you can't social distance.
Dr. Adalja, let me just ask you one last question about something that I find both concerning and really intriguing in the news over the past few days. And it's this news that first it was 5, then it was 8, now it's apparently 13 sailors from the USS Theodore Roosevelt who tested positive, who were believed to have recovered. All of these sailors reportedly had at least 2 negative tests after initially having had a positive test, but now these sailors have tested positive again. Looking at that, do you think that is probably an artifact of the testing not being that great, and so maybe we had false negatives or false positives? Or is this potentially a window into the prospect that people can be reinfected after they've cleared the virus and recovered from an initial infection?
My best analysis of this is probably a testing artifact. We know that people can toggle between positive and negative when they're near the limit of detection. We know that people can cough up or have remnants of the virus that can be detected by the test. So I would want to know a lot more about these cases, but there's no strong evidence that you can be reinfected in a short period of time after infection. We've seen this in South Korea where they actually were able to try to cultivate the virus and they couldn't actually grow it. So that may just be non-infectious and it may just be the test toggling between positive and negative because of viral debris. At least that's what we hope, and I think that's what most evidence points to.
Dr. Amish Adalja from the Johns Hopkins University Center for Health Security. Thank you for helping us put some facts on those news stories today. I feel like the scientific basis of a lot of what we are talking about and deciding as a country right now is getting really wobbly. It's helpful to be able to go to you for expert advice. Thanks.
Thank you.